going to discuss is all about medication, how we manage our patients' medications. So we have 6 different questions here. So our goal for our patient or caregiver is able to answer the following questions and then for discharge. Sorry, I'm nervous. Okay, so questions are, who ordered my medication? So we make sure that the patient and caregiver knows who ordered those medications that they've been taking. Second is, what medications should I be taking? Where do I get my medications? When do I take my medications? Why do I take these medications? And how can I improve my medication safety? So it's really important for these 6 questions to be completed once we discharge our patient. Any questions on this? Okay, so Jen and I and Whitney made this medication reconciliation form. I tried this for 3 times already during my visit. So based on my experience, it's really good for me. It's really a good tool for us to use this in every visit that we, go to our patient. So there's a lot of, as you can see, there's a lot of different columns here. These columns is completed by admitting clinician, which is us. So basically medication, dose, route, frequency, and indication. The one that we're trying to emphasize here is, so during our SOC initial, we mainly go reconcile medications to source, which is inpatient record. Mainly this is from the discharge summary from the hospital. Second, we also do it from the MD or the RX file that is included in the house, that found in the house. What I recommended is, it is important for us to reconcile the medication if the patient went to follow up with their PCP after they admitted. So this would be invalid. So the most updated medications that we need to update in their chart is from the MD. Source also is from the patient report. Other part is patient taking, not ordered. These are the medications that patient is being taking, like vitamins that wasn't being ordered by the doctor. Medication that was ordered but patient not taking. So I know some of our patients, there are some patients out there that they're not uncompliant with all the medications that the patient or that the MD ordered. Yeah. So medication that adjusted in the hospital and discontinued in the hospital, mainly during SOC, we can see this on the discharge summary, discontinued in the hospital. So write the medication and just check it there. And there's also the new medication. So I can also see that in the discharge summary. So any medications that was highlighted with this 3 is you can write it down and check it out. So this column is starting from the red color here, discontinue medications, add medication, change dose, change frequency, and special instructions should be completed by the doctor. Because this reconciliation form was to be given by the patient, and the patient is going to bring it to their MD for their next visit. So I would recommend all of you to try it out. What would be your feedback on that? On this medication reconciliation form that we made up.
Just so you know, I'm gonna let Hazel and Whitney finish up. We're gonna come back to this reconciliation form, okay? Next slide.
Next slide.
Okay, so your worksheet here, okay? So here's the idea, right? The very first had all like the 6 questions, right? That's the idea, that you want your patient to be able to answer all of those questions. This worksheet is something for you to be able to fill out with your patient. It's interactive. It's not gonna happen at the start of care, okay? Remember, medication education, this whole thing, this whole packet is to help you guide you through the episode. So this worksheet is probably something you're gonna fill out on the second visit, the third visit, something like that. Maybe you're only filling out some of it, whatever you have time for, right? But how do we know why our patient has difficulty taking their medications? Or actually, how do we know that our patient is great with their medication? This is actually designed so that they're not yes, no questions. You ask them the questions so that you can identify where there might be issues, and then that's what's going to help guide you through the episode as to what you're trying to fix. So, like, if they tell you, right, like, that they have a difficulty paying for their medications, and that they don't take 2 of their diabetes medications by the end of the month because they can't afford it, that's a barrier. That's not just saying non-adherence, right? There's a reason for it, and that's what we're gonna start working on with them. Okay, there's all kinds of things that we could do in terms of getting them coupons. Maybe their doctor needs to do a prior authorization for them, whatever. These are just other things. This worksheet is to help you identify what it is you're going to be doing through the episode. So, yeah. There you go.
So about half of you folks in here have been here for a very long time, and some of you, about the other half have been here for a year or less, right? In the past, we've told you folks to ask at every visit about meds, but that question mostly has been, have there been any changes with your medicines? And that's not really what we wanna know. We wanna know this instead. We wanna know, are there changes, but also are you having problems with your medicines? So use this worksheet here to help guide at every visit when you're asking about, is there any changes, but also, are you having any problems with any of these things on this list? So you can kind of nip it in the bud right away, okay?
Worksheet needs to be filled out around second or third visit, okay, honestly. And if all of the answers are good, right, that's how you know that I get to discharge in 3 weeks, right? Medication management, 1 week 3, that means there's zero problems, okay, type of situation. Anytime that you got problems, now you know what you're doing.
So sometimes we run into this issue because there's knowledge deficit, like they don't know why they're taking this medication, and what it's for. So we kind of explain to them what it is. And then some of them they can't read what the medications are because they're blind, right? Like how do we know if they're taking the right blood pressure medications or diabetes medication? So we gotta figure out like what's really why they're not taking these medications. Some of them, like they mentioned earlier, like could be too expensive. You know, they only have like a month trial, and then by next month they gotta pay $600 out of pocket, so can't afford it. Fear of addiction. So some patients, I do run into patients sometimes, and they say like, no, I don't want to take Vicodin because I feel like I'm gonna get addicted to it. You know? And it's like, no, it's not that it's not addiction. You're in pain, you need it. So you don't want to just wait till like you're above 10 or something, and then you can't bring it down. So we just kind of explain to them the difference between tolerance and addiction. Okay, you know. And then so I guess some patients, they kind of accidentally, you know, fill the bottle or something like that. And most of the time insurance don't cover it because it's a mistake or something. But I guess we just have to talk to the doctor and let them know what happened. Some don't like to take the medication because their beliefs. Like I don't know which one would be a good example. Or some of them will say, oh, I forget to take the medication. I know I was supposed to take it this morning, but I forgot. So So maybe like we can look into something like, oh, where do you eat breakfast? Like, where do you put all your other medications? So sometimes like I have one patient that I have, tell them to put his medication with his, I don't know where I put it in there, but he puts all his medications in one area and then he knows to take it in the morning. So that's one of them. Some of them, they can't swallow it. Maybe the pill's too big. So we gotta let the doctor know, hey, you can't swallow it. Or they just don't have their medications organized. So there's all over the place. You have the pill bars all over the place. One is over there, one is over here. So we kind of like, hey, bring all your medications over here and let's put it in the pill box. Yep. And then so we put all over here. So who can actually go over these medications? So like RN, social worker, OT, speech therapy, or like each in different departments.
Right, so after you do your worksheet, then you've identified, right, some of the possible causes, right? Circle them, right?
Okay, so, this one, during the start of care, like, you know, sometimes we run into issues, like we've had medication from, say, last year. You know, so like, hey, let's discard this, because you're not supposed to be taking it anyways, you know? So I definitely wanna, remove it. Also, if they're taking like, say, 2 or 3 different antibiotics, and they actually only need to be taking one, maybe we can reconcile or just make sure they're supposed to be taking what they're supposed to be taking, not just like 3 different ones. Oh yeah, sorry, that's the drug activity. So, so I guess kind of just figure out like what is their daily routines and what they can remember to take it. So same thing with the other one. Also, oh my gosh, yeah, pretty much everything explained it all. Oh yeah, and then also discontinue medication and cautionary meds. So some patients they might have like 2 of the Carvedilol, 6 point something, and the other one is 12 point something, right? So then they don't know which one they're taking, but they're supposed to be taking the higher dose. But before they went to the hospital, they were taking the lower dose. It's like, oh, which one do I take? You know, so you just gotta verify all that. So, and then we take a list of our management plan.
In addition to that, some medications, there's a lot of specific instructions in their RX bottles, so we need to be mindful of all of those instructions given by the doctor, because some medications they cannot chew, they cannot crush, or they cannot eat with a certain food or something like that would interfere with their medications. So I think it would best for you know, another educational for the patient to be mindful with all those instructions that they're being given.
Right, so before we identified barriers, these are your interventions, okay? Figure out which interventions are gonna work best for your patient, right? These just give you ideas of things that you can do, and then over there, that 1 through 7, right, write it down. So this, you know, so maybe they don't have any expired medications, so this, or old ones, this isn't really gonna apply to you, but the single pharmacy thing, maybe that really would work for you. So for number 1, basically, as part of your plan is, coordinate, medications to be delivered from 5 Minute Pharmacy. That's part of your action plan, so write that down. Non-drug alternatives, maybe they're on a lot of pain medication, right, that they don't, right, maybe you're going to suggest using some, you know, alternative therapy, instead. Write that down. So that's why I say this is just to kind of help guide your interventions, give you ideas of what to do.
Okay, next that we need to discuss is all about medication disposal. This is very important on how we dispose our medication. So basically, when they dispose of medication, when they're expired or no longer needed. So there's our different options on how we dispose our medications properly. So we can mix it with an appealing substance, place it in a sealed container, throw it in a household trash, and make sure that we scratch out the personal information, because this is all about HIPAA. And, you know, people nowadays, they got all information and everything. So it says here, it is important that don't trust assets and a child or animal could ingest it, and also don't flush it. This can contaminate rivers or any sources of drinking water. We have also, we also included here the medication drop boxes. Yep, Department of Public Safety, you can see it over here. They're open Monday, 8 to 4 p.m. except holidays. So it is really important to have this, also to educate the patient about this.
So we came up with a list of, like, I guess some patients, they need a blister pack, or they need compliance packaging, or any of these, right? So we came up with a list of, like, pharmacies that across Oahu, where they actually provide these things for them. You just kind of have to tell them when they take these medications, because if not, they'll just put it right in the morning, or, like, you know, some medications go in the afternoon, so they'll put it in the afternoon, in the form of a blister pack or another one. So like if your patient can't open up the bottle, there's just a flip thing that actually you can do for them. Okay. And then they deliver.
Because you identify, right, at the pharmacy that is near your patient's house, and they're like, oh, yeah, that sounds kind of great. The physician itself is who needs to be notified, right? So please please transfer all of that patient's prescriptions to this pharmacy, right? Or they want to try compliance packaging, right? That's actually how it happens, is that the physician then sends prescriptions to that pharmacy, and then they should take care of it,
So like
from that point.
if they've had prescriptions from other pharmacies, the physician literally has to write new prescriptions to the pharmacy they want, and then they'll reconcile it to where they'll have enough for that month, and then however insurance can cover that kind of stuff.
But the doctor's office can take care of that.
Yeah.
It's
I had issues.
Well,
had to do
they're
it.
supposed to be able to take care of it.
Yes,
I had to do it at one point because the doctors were.
Well, but we really can't. I mean, that is the idea. We help identify what it needs to be, but we can't truly send their prescriptions there. Only a physician can.
I mean, like, I had to call them and then, like, keep telling them, and every time there's a new prescription, they'll send it to the old pharmacy, and I'm like, no. I had to just-
Maybe they need a new PCP, not a new.
And then just as a addition to that one screen, Walgreens will print labels in different languages. So the ones that I know they do are Spanish, Chinese, French, Polish, Portuguese, Russian, and Vietnamese.
Oh,
But
wow.
I'm not sure if they do any other languages. I saw this once earlier, but I'm trying to find it. But yeah, so you might wanna just ask some of the pharmacies if they do other languages.
Oh, that would be great. Because most of my patients, like Chukis, I have a Chukis patient, they write it out with their Chukis thing, because they cannot really.
Yeah, I had one.
They send a prescription that language, what do we do?
I know. So I also had a patient once where she only spoke Cantonese. And so the son and I I told him what they were, he wrote it down into Cantonese for them, and then we did symbols. And then she put the little symbol stickers on the medication box so she knew where to put it all. So it was like a language thing, but it was also coded so they could do it themselves. So there's lots of ways you guys can encourage independence if you have a language barrier.
Yeah.
Do you have any sample of that? How does it look like at the bottom?
I don't have a sample, yeah.
This is like the problem, the good is that you guys can read when we go there without,
Yeah, that's what Marcella just said too. And then,
I had to go once, I had like, it was all in Korean, and I was like, how am I gonna reconcile? I have to get the
Oh, I
pills,
wonder if
Google
Google-
the pill for each bottle to figure out which
Yeah,
one
they're
it
Google,
was.
yeah, Google Translate, right? Yeah. And then Natasha, you guys know our HCR Natasha, when she was in the field, she actually had a blind patient and they made his labels in Braille for him.
Oh, cool.
Yeah.
That's why I think.
That's awesome. Newtown also delivers. Newtown pharmacy. Oh, did I miss the X? Oh, sorry. Yeah, they deliver. Yeah, go ahead and put next there. Actually, that's the whole point, is that they deliver.
So you're,
Actually, I think I put the X in the wrong spot, honestly.
You're-
Pharmacy in KKB and Kali already shut down last year.
Okay, they all gone. Okay, we'll take that one out then.
Pharmacy.
This is why we.
KKB.
KKB and Kali.
So know that for the handouts that are already made, right, just scratch it out and then I'll adjust it for the next ones.
the Walgreens and Walmart have the same phone number, is that correct?
Oh, yeah, here and this one, then maybe.
But they did actually on the thing, on the sheet that you gave, but that's okay.
Okay, we'll
Yeah.
update it.
Maybe it's Walgreens in Walmart.
Maybe, hold on a second.
I just have a suggestion. Can this handout be pinched in our SOC books?
Yes and no.
Yes and no.
Parts of it, but no.
So then
Because
we can reconcile it with them?
that one will, eventually.
And the worksheet.
Eventually,
Mm.
eventually. So, but like this kind of stuff here, if you think about it, this is for you guys as nurses, right? To be able to just kind of give you some extra tools when you're doing your ordered for medication management. When therapy, when they start the case, their kind of thing is my patient having problems? And if they're having problems, then they're gonna call in the nurse, and then you're gonna basically start this kind of process. So that's why the whole thing would not be in the starter care book. Okay. Thanks for telling me I'll fix that.
That's why we're collaborating.
This is why you should do things at midnight.
Okay.
Looks good, guys,
Yes.
okay. And then, yeah. Oh, and then, yeah, it's just some extra QR codes for you. Oh, actually, I think the reason why we brought this up for you guys is you all are very tech savvy, but our old people, they are not. But then what I think, like when I think, for example, like the CVS pharmacy one, think of how many patients just go to Longs and have their prescriptions filled. And yet they don't get them refilled because they can't get there, and yet they deliver. But if we could just help our patients set up, like, you can use your phone, like, be like, you have an extra care card, right? If they do, that means you can help them get set up with your phone even, to type in the information so that those things will start getting delivered to them, so, yeah. That's what the QR codes are really for, they're really for you to easily be able to get to the website. And like, that don't take you time, right? That's like a 40-minute visit right there, is helping them get set up with delivery. But that's okay, that in itself is your visit. That is the whole visit, and then they see it. Cool. That's about it.
Yeah.
Yeah. Okay, back to that one. That was good, guys. Because I really want to get back to this actually, because the discharge list actually kind of goes along with it. So, reconciliation. As home health nurses, guys, this is something that we own in the community. That reconciliation process. And so we want to make sure that that you are able to have the easiest, to get the most complete information and to be able to get that to the doctor and to get this process done so that by the time we discharge, we know that our patients have the most accurate, up-to-date medication list. And if we can do that for the people in our community, like, we're stars, okay? So, the reconciliation form should be initiated at the start of care. And to be really honest, it's not really negotiable, okay? This is something that we are gonna implement, because as far as Medicare guidelines, we are required to provide our patients with a medication list. Doesn't say in what form, okay? So we're gonna start doing this at the beginning so that we know that we're starting them off with at least what they're taking, okay? And then we will work on this as we go along, because you're gonna find that there are gonna be errors, and you're gonna start marking this up, right? Right from the very beginning. There'll be a final discharge list for you to be able to, once you get everything worked out, okay? But again, this is for you guys to basically walk into that house and say, show me everything that you're taking. That's the point. What are you actually putting in your mouth? Okay? And you start writing these down. After you've basically written it down, and be quick about it, be quick, I mean, when I say indication, heart, blood pressure, reflux, right? You don't have to write a book about what the indication is for. This is not necessarily, this reconciliation form is not for you to be teaching off of per se in terms of what your medications are for. It is truly for reconciliation. And then after you've written down, right, then you're basically checking here. What am I reconciling that carvedilol from? Was it the inpatient list? If yes, then go ahead and exit, okay? Or if it's an office referral, was it from the office, from the office referral? Or was it from the prescription bottle, okay? And basically a signed physician list and a prescription bottle, they're the same, it's the same thing. And then just so you know, like care homes are a little bit different. Some of them are really good, like if they're following DOH rules, then the list that they have in the house has also been signed by the physician, just so you know. Some of them aren't. These last two things are really for you guys, because I know you walk in there, right, and your patient is taking this medication, but you don't know who ordered it, right? So that's what that box is for. And then the other one is that you see that medication name, it's on your discharge summary. They're supposed to be taking it, but they're not. But you're still, you're writing it down. Amlodipine, right? And it's ordered, but the patient's not taking. That kind of includes the same thing as missing. That's it, right? These actually ones in pink here are just kind of to maybe just provide a little bit extra detail, okay? But that's the reconciliation part of it. Any problems that you're identifying with it, take a picture of it, okay? When you're on your Tiger text, you're gonna bring up your CDI, your CDI attachment thread. Instead of hitting you go to hit the camera, and then it'll ask you, do you wanna do photo, video, or scan? If you hit scan, it creates a PDF file. It's gonna go to CDI, and Kiana's gonna fax it to the doctor. So you don't need to write that MRS note anymore that basically is like, oh, patient's got this and this, but doesn't have this, and he's not taking this. That's what this is for, okay? That way, if you check the boxes, we're gonna fax it, and then this part here is what the doctor's supposed to fill out. So that if the doctor doesn't want the patient to take it anymore, he can discontinue it from here. If that dose actually has changed, right, then they can write it in there. Or they can sign it and be like, okay, that's good. Patient is taking it, but you don't know if it's ordered, and he just signed off on it, it's now ordered, okay? So the tool is actually there to also make it a little bit easier with the reconciliation process. But I will tell you that this whole thing is probably gonna take you an extra, right? It's gonna take you an extra 15, 20 minutes. It's 15 minutes at the start of care. Just wanting to say 15. But that's what we do, and that's what we started off with. And if you go in and the thing is a mess, right? Their medications, they've got like so many pill bottles and it's all a mess and you didn't get a discharge summary and you're like, seriously, what did you want me to do with this? Okay. We have 5 days to complete a start of care, okay, in terms of all of that, in terms of gathering all of the information that's necessary. You go in and it's a mess and you're like, I have no idea how I'm gonna accomplish it. You text your staffer on your staffing thread and you say, I need an RS. I'm coming back. I'm gonna finish this up. It's fine.
Make sure you
And
ask
we'll-
for the RS before you complete your SOC, okay?
Yeah,
Don't complete and sync, has to be before you complete.
right. Yeah, the RS has to be plotted before you sync it, just so you know. Make sure you text, like, when you identify, oh my goodness. But I just want to know that, give you that, you know, to let you guys know that that is an option if you go in and it's a, blah. Thoughts on this?
I have a question.
Yeah.
The discharge, I'm sorry, discontinued in hospital, if they don't have the medication in their home, but you see they were on something in the hospital and got discontinued, do you still have to write that one? Or if it's only in the home still and you see on the med list it's discontinued?
Only if basically they're pulling out the pill bottles and you say to them, what are you taking? And they pull it out and they set it there, I'm like, oh, I'm taking this. You would I would actually myself write it down, right? That, for example, amlodipine, because they said they're taking it, right? And I probably would make an X mark on that discontinued in hospital, and I would make a really big point of saying to the patient, this medication, right? Circle it, this medication was discontinued in the hospital. But I would actually want to send that to the physician, the PCP, because he might be like, what do you mean they stopped your calcium channel blocker? You're back on that, right? So I do think that those are good, really good points. Again, this is a reconciliation process.
Is it possible to get a PDF file of that? Because sometimes there are so much medications that we get, like, for the med list, just so that, you know, we can work on it before we go see the patient, and then we can just cross out whatever's not in there or whatever.
What was the question?
PDF.
Yeah.
We can add it, we can add it to the Teams,
It's all,
and then you can access it, oh my god, access it through MicrosoftOffice.com. You can pull it off onto your computer and print.
Mhm.
Yeah.
It'll be there. The whole presentation will, this in itself will be set up as its own file so that you can, yes, pull it off and grab it as you need. And you guys all know you can work off your OneDrive, right? Like off of any computer, you can log into your OneDrive. If you don't know what I'm talking about, come see me, honestly, and we can help you make sure that you can access it from your home computer. And then, so, that last part is a discharge medication list, right? So again, the before one was for reconciling and figuring out all the problems and blah, blah, blah. By the discharge, right, you should pretty much have it set, right? We have it all set up, so like now at this point, you're just writing down the names of the drugs, who prescribed it, and then make a little X. AM, PM, whatever's, and then they have that list to have and hold to love forever. So yeah,
Will they still be receiving the med list after SOC, the meal med, not anymore?
until whatever, it's March, right? It's March, therapy has their meeting at the end of March, right? Because this has to include them also. Once you guys start now doing it and let us know what's working, blah, 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 then it's gonna be introduced to the therapist. They're gonna start it, and then probably around April, somewhere in April, once everybody's on board, yes, we will stop mailing them.
Can you explain again the part about Kiana faxing? Because we still have to call and try to, in order to meet our next day requirement when there's a medication issue. You can't rely on faxing it every time.
So, So you know the OASIS question that's basically asking you to, have we, resolved some medication issue within 24 hours? So that is true, right? The first thing that you are supposed to do when you identify any kind of problem is to try and resolve that with the doctor. And you might be able to get that answer right there in the home, perfect, and then you can educate right there. That sheet, regardless of whether you have problems or not, right, is to be filled out. It's an aid if you're not able to get a hold of the doctor, and then we can fax it for you easily. But yes, please attempt first to call the doctor. Does that help?
Yep. Just wanna make sure it's not replacing
No.
that step.
Okay.
And even now, when you folks have, that clinically significant issue or the med interaction thing, that does not replace your phone call. Okay, so you still need to call. Okay, so, we are reinitiating our quest to be perfect at M 2020. For those of you who don't know, this has been ongoing since like 2007. I was part of the committee in 2013. So what we need to do is improve our score, meaning that if our patients have been identified as able to improve in their independence in managing their own medicines, that we get them to improve. In the period between October and December last year, we had about 750-ish people who were eligible for improvement and only about 250 actually improved. Okay, so that's a very low number. We'd like to get it up higher. Just so you know and you don't freak out, the national number is about 80, we're at about 62. So we're not that far away from it, but it could be better. Okay, so that means what we're trying to identify is, do they know how to safely, reliably take their medicines on their own? Okay, so this goes back to, you gotta know what your med is for, when to take it, how to take it, all of those types of things, right? This is only for oral medications. It's nothing to do with your eye drops, your inhalers, your injections, or anything, okay? We wanna know that they can take the correct medication in the proper dosage at the right time. 3 of your 5 rights, right? Or does somebody have to prepare it in advance for them? So they make them a pill box and you're calling and saying, and you're preparing the pill box for them, they can remember to take it, okay? Or somebody else has to make the thing for them and call and say, hey dad, don't forget to take your meds, okay? And then, are they also unable to take their medicine at all reliably? Okay, this has nothing to do with compliance. This only has to do with their ability to do it. So part of what I was trying to get at in the survey I sent to you folks is that these are the things that we need to consider when we're assessing our patients to determine how to answer that question. So we're not only talking about do they know what their medicines are for, but we're also talking about can I understand the instructions of when to take it? There's parameters. Do they have that cognitive ability? Can I swallow the medicine and can I swallow the beverage, right? Do they need a thickened liquid but the speech therapist is working with them? Is the pill too big? Does it have to be crushed? Can they physically get to where the medication is stored? That's physical therapy, right? Ability to use a blister pack if it were available. That's occupational therapy, being able to open those things, the pill box, the flip top lips, all of those things. Their mental alertness to know whether or not, did I take this medicine already or do I need to take it? Did I take it twice? Those types of things. Do they need that reminder? Do they need an alarm clock? Do they need notes written all over their house? Ability to read at all, right? If they can't read the label, then how are you gonna teach it? If it's not in their language, how are you gonna teach it? If they're blind, how are they gonna teach it? Manual dexterity, similar to this ability to open bottles and things. Hand-eye coordination, are they dropping the pills on the floor, right? Language barriers, like I mentioned with my Cantonese patient. So all of these things go into what we call the OASIS walk. You really should be having them say, make sure, or you should be telling them before you show up, please bring out all of your medicines for me. And then have them demonstrate, here's the bottle. Or where do you keep your bottle? Let's go to it. Okay, now can you read it to me? Do you know what that means? Can you open the bottle? Can you show me how you would put it in your mouth? Take it out of the bottle. Do the whole thing with them so that you know whether or not they're able to follow that whole entire process. Okay, so now if we go back and we look into the oral med management survey, I'm gonna show you some of the responses. Oh, wait, I gotta refresh. I think more than 9 of you answered it. There we go. So here, how often do we provide a written list? That really should be all the time, whether we provide it or not. Now we're using this new medication list, this should always be always, right? And then thinking about how you're gonna teach the medicine. So that handout that Whitney and Hazel gave you folks, that's gonna help us to be able to write down all of these things, the purpose of the medication, the dosage, the side effects. That answers M2005 later on, because we need to be able to say that we did talk about those specific 3 things. Do you include the following? So this is what I was talking about, that manual dexterity, everything that was on that last slide I showed you. I'm very glad to see that some of you, in the original survey, somebody said that they only explain high-risk meds. So you should be explaining all their meds, not just the high-risk ones, okay? Number 5 was just more informational for us. Number 6, assessment of how you know that they understood you. So again, use that handout that Whitney and Hazel are providing to you folks. And then here, number 7, how often do you assess the patient's full ability to administer their own medicine if they live in settings such as foster care homes, adult living facilities, to birth, those types of things, because those are the times where they're not allowed to touch their meds, right? But can they? Michael has a patient right now who is living on his own, and now he lives in a care home. But the only reason he's there is because he's homeless, but he can totally do all his meds. So we're not assessing the caregiver, we're assessing the patient's ability to be able to do that. Even if you have Mrs. Chong who's like, that's my husband's job. He's always done my meds for me. You need to assess Mrs. Chong and say, I don't care if your husband is the one who does it for you all the time. I need to see if you could, if something drastic happened to him, right? Something like that. So make sure you're assessing the patient's full ability, no matter what circumstance they're living in. Parameters, I'm glad you folks are looking at this, to know that they have the tools and able to check the parameters. This number 9, if the patient is missing 1 medicine, how do I score M2020? It was previously that if they were missing 1, you would have to say unable to take. Just recently, like within the last month or so, they've changed it for you to use your own clinical judgment about it. So if you think they can open all 15 bottles and 1 is missing, then you can go ahead and say yes, if the bottle you think is similar. Or if the one that they're missing is their Colace, but they poop every day. It doesn't matter that they're missing their Colace, right? So you would score them as according to all the other medicines. So, Nisha.
Just make sure, like, if it's a new medication and they haven't picked it up, they've never used it, think about, can I trust that they would understand? I'm here to provide the education, so it's okay to mark it that they need someone else. And then at your next visit, hopefully they'll have it and you can assess and then show improvement, and they'll be better later.
Right.
Yeah.
And then the last couple of questions were just more so that you guys were aware. So now today, you know that there are pharmacies that provide medications in different language, or bottles in different languages, blister packs, the daily packets, they tear off, this is Monday's packet, this is Tuesday packets, kind of like how you guys get like those vitamins from GNC and stuff, right? So this is just more an assessment for us to figure out where we're at, how you folks teach, how you folks are figuring out that they've learned from you, if we're ready for discharge, and where all of our snags are, so that we can help to improve their ability to manage their own meds later on when we discharge them, because we really want to get that rate up higher. Our goal right now that we've set for the agency is about 70%. That's what it was back in 2017 when I left off. So we're gonna get it back there, hopefully. And if you guys have any feedback or questions or anything about what we asked you about today, or presented to you, then please let us know. But pretty much that's it. You guys have any questions?
Can I just say one thing? So with the medications and actually getting to the medications, it also includes getting water or some beverage to take it with. So, you know, if the patient's sitting there, they have all their meds set up, and the daughter brings a bottle of water, you know, can they open it? Can they open a new bottle? Again, OT, PT. And it's most important for this question at your starter care to answer it correctly. And because, you know, if patient needs help at starter care, whatever level, hopefully we go in, we do interventions, and they are improved by discharge. So that first touch with the patient is probably the most important for any of the OASIS, but especially med management.
Yeah. And like Jen said, you know, it's gonna be non-negotiable for us to be able to do this. It's always been non-negotiable, but the mindset that we need to have about how important this is needs to change. When we're scored on these things nationally, this is weighted pretty heavily because it's safety, it's danger, you know, this is reasons why people end up in the hospital, you know, we don't want people to overdose and those sorts of things. Okay, I think that's it.
We'll shoot out some like examples, right, some hard, like, using examples on the 2020 of like